Module 3, Management of Long-Term Cognitive and Psychological Post-concussive Symptoms and When to Refer. While there's an adequate body of research literature about the symptoms of TBI, less is known about the treatment and long-term management of these injuries. There are published concussion management guides for primary care providers. However, studies of PCPs have shown that anywhere between 20 and 68% of providers are aware of these guidelines or consult with them. Links for some of these guides are provided in the Resources tab. If a patient continues to suffer with persistent post-concussive symptoms beyond the acute phase, the following are suggested. First, evaluate and rule out potential comorbidities such as PTSD, substance use disorder, depression, and other potential physical health problems. Often, persistent cognitive or psychological complaints are due to other factors. A reminder here that patients are more likely to attribute cognitive problems to a concussion rather than to other more likely culprits. The next suggestion is to provide education to the patient. Currently, the Department of Defense and the Department of Veterans Affairs recommend psychoeducation as the only evidence-based intervention for mild TBI. Although this may be partially due to a shortage of well-designed cognitive rehabilitation studies, it's an important reminder of the importance of psychoeducation and managing patient expectations. As an example, imagine you're seeing a college student with a mild TBI who continues to complain of attentional and concentration difficulties 4 months post-injury. You, the provider, might inquire about other personal or environmental factors. For example, is the student using substances such as tobacco or caffeine that could alter attention? How is his sleep? Is he experiencing increased stress, such as an upcoming exam? Did he experience problems with concentration before the head injury, such as childhood ADHD? Probing the patient about other influences may help disentangle post-concussive symptoms from symptoms associated with other disorders. It's important to offer guidance to patients, particularly around managing symptoms. Initially, this will include educating the patient on symptoms they may experience after a mild TBI. Once the patient is aware of what to expect, they can then take an active role in managing their symptoms. This may include taking steps to minimize the impact of their symptoms by making temporary environment or lifestyle changes. For example, if the patient experiences headaches, they may find that decreasing time on digital devices helps to decrease the frequency or intensity of headaches. Patients may be unaware of strategies to manage their symptoms, thus opening a dialogue that will allow providers to cooperate with the patient to brainstorm helpful strategies. Patients can benefit from education on various topics such as proper sleep hygiene, relaxation techniques, coping skills to manage stress, and other health behaviors such as limiting the use of caffeine, alcohol, and tobacco. Providers should discuss with patients how healthy behaviors can be beneficial in the recovery process. When providing education, it's important to offer reassurance and normalize the patient's experience. As mentioned before, patients may have misconceptions when it comes to outcomes after a TBI. Educating the patient on what to expect throughout the recovery process can help to reduce distress. It is also important to provide support and psychoeducation to family members for a number of reasons. Family members may help remind the patient of information if they continue to struggle with memory problems. Dealing with a patient after concussion may be difficult and stressful for the family. Additionally, family members typically have their own anxieties and concerns regarding the injured patient. Therefore, it's important that they have an idea of the projected outcome and realistic expectations for recovery. As described in Module 1, clinicians should convey realistic but positive expectations for recovery and encourage the patient to progressively return to their normal pre-injury routine and lifestyle. Patients may be hesitant to return to normal activities, but providers may help by effectively empowering the patient to self-manage and actively participate in the recovery process. Psychoeducation should also cover prevention of future injury. Factors such as a previous head injury, especially those that include slowed reaction time and impaired vestibular functioning, increase a patient's likelihood for additional head injuries. When returning to normal activities such as sports or work, it's important to counsel patients on avoiding re-injury. This is similar to educating patients about potential environmental risks. With older adults, prevention of re-injury may include monitoring medications. For example, medications prescribed for comorbid conditions, such as sedatives, hypnotic medications, antidepressants, and benzodiazepines, are associated with falls in the elderly. Patients may also benefit from general safety tips, such as being cautious of potential hazards like spills or ice. Finally, encourage the use of protective equipment, such as helmets when biking or anti-slip mats in shower areas. When managing concussive symptoms, it's important to educate the patient on how to access further support or the other options available to them if they continue to struggle. For example, you may provide information on accessing substance cessation programs, further assessment services such as sleep studies, or psychological services to manage comorbid conditions such as depression. We will give more information about referral resources in the next section. When managing patients in a primary care setting, case managers can be a useful resource for additional support. Case managers can assist the provider in ways such as coordinating and reminding patients of future appointments, reinforcing early interventions and education, addressing psychosocial issues, or connecting the patient with other resources. It may be difficult for PCPs to determine when to refer patients. To address this, the VA and Department of Defense released guidelines for practitioners on when to refer. First, if the patient continues to complain of symptoms 3 months after injury and the persistent symptoms affect functioning. Second, if symptoms have been resistant to treatment, such as prolonged sleep disturbances or continuous headache complaints. Third, if a patient complains of cognitive symptoms, before referring, PCP should consider the strong evidence recommending that comprehensive neuropsychological testing should not be performed during the initial 30 days following a mild TBI. If self-reported memory, executive functioning, or attention problems do not resolve after 3 months and have been refractory to treatment for related symptoms, then consider a referral to a neuropsychologist. Neuropsychologists can assess cognitive functioning problems and recommend strategies to improve these issues. If warranted, neuropsychologists may also refer the client to a cognitive rehabilitation specialist. In the majority of cases, routine referrals to specialty care are not recommended for patients with mild TBI. Additionally, when contemplating a referral, remember that substantial deterioration of functioning or worsening of symptoms past the typical recovery period should trigger consideration of comorbid or even competing diagnoses. Additionally, referrals may be made to psychologists or similar mental health specialists for various reasons, including chronic pain management, substance use treatment, depression, anxiety, or PTSD requiring psychotherapy or more complex medication management, anger management, to address diagnostic issues, for treatment recommendations, to address other areas of functioning, and assistance in discharge planning and continuity of care. For more information about referral sources in Colorado, please see the attached referral handout. You have now completed the training. This training has covered assessment and diagnosis of concussion, including the definition and common causes of TBI, severity ratings for TBI, and the assessment of mild TBI. In the second module, we covered cognitive and psychological symptoms related to concussion and common comorbid conditions. Here, we discussed cognitive and psychological symptoms that are commonly associated with mild TBI and how to assess these symptoms. In addition, we discussed common patient misconceptions, the limitations to self-report, and risk communication. Finally, we discussed disorders that are commonly comorbid with mild TBI and how they may affect treatment outcomes. The third and final module discussed management of long-term cognitive and psychological symptoms, educating patients, and when to refer to specialty services.